productive session. Thank you.
Thank you. Okay. Well, so we're just going to go ahead and kick off this session with a few interesting updates. But first, we have just a short list of 43 regs to review. Everyone should have received the summary of the regs and the live link. And I just wanted to, for some of our new members and maybe as a refresher to all of us, that the regulations that we hear are first reviewed in the Administrative Regulations Committee. They are then referred to Health Services or the Committee of Jurisdiction for review. We do not approve regs, but we review them. We can find them deficient, and we can defer regs back to the cabinet or to whomever is working on this for further work and an amendment. And doesn't happen often, but sometimes there's a regulation that needs a little bit more work. And so we always appreciate the work of the cabinet on getting those right before we review them and send them off for implementation. So that's generally what happens. The regulations having been reviewed by administrative regs and our committee go into effect upon the review. So that is generally speaking what we do. Now we have a lot of regs that you have before you today, and I am just going to ask the committee if everyone received the summary and if there are any questions. Representative Callaway.
There were three that jumped out at me that I had a question about. The 202 KAR 007 330 regarding EMT, and then the 301 regarding reciprocity. I just had a question about it being extended to all states versus the contiguous states. I wanted to be clear that's what exactly was happening, and if the only requirement was the individuals are in good standing, their licensure. So,
do we have anyone from the cabinet who could discuss this? Thank you. If you can just introduce yourself for the record and help answer and clarify that question.
Thank you. Eddie Salon, Kentucky Board of EMS, Executive Director. And to answer your question, correct, it would be any state. In lieu of the compact, it would do much of what many of the compacts would do, except for it's a little bit more of our own in-house twist until we think the compact's in a little better shape to fit the needs of Kentucky. But it would allow those that come with it in good standing of another state that use the National Registry as the test to come to Kentucky and get their license if they're in good standing.
If I may follow. So is there a reason that we didn't land on that initially, why we said specifically contiguous and why we felt we needed to?
I don't know the answer to that. It predates current board staff. So it was there for many years, and so we just updated it, make it more friendly for somebody one state over, several states over. So I can't answer that. I'm sorry.
I can help answer. This is John Wood. I'm the counsel for the board. Sorry, I'm attending by Zoom. So there's a prior statute. It was KRS 311A.142 that specifically limited it to contiguous states, and that was amended, I believe, the last session or maybe 2 sessions ago to change that language.
Okay, I think your puppy has something to say about that.
Yes, he does.
Okay, thank you. Okay, does that answer your question?
I guess it does. Thank you. And then I did have one other regarding 008-610, the dentistry. I just wanted to learn more about that. Governs certificate communication. I've just jotted notes down. I'm sorry. I was trying to find the actual email where I could pull up the reg. Governs healthcare workers in a dental health setting under dentist supervision. What's the change there and the advantage of the change?
Okay. Do we have anyone who can speak to that from the cabinet or dental folks? Okay, I don't see anyone who is here to speak to that. It has to do with the licensure of dental hygienist. Is that the regulation that you're looking at? So it says that this reg was amended to make several updates to the dental hygienist licensure process, and it clarifies that applicants can meet licensure requirements either by completing required clinical exams or by being credentialed in the U.S. It also made some changes to address the reinstatement fees for expired licenses and specified that dental hygienists administering local anesthetic should do so under the direct supervision of dentists. I think it's clarifying the licensure and the scope of practice for dental hygienists. It doesn't look to me like there are any real changes in the personnel. Is that your question?
Yeah, it was the supervision part, whether they were currently required to be under supervision, if they had any leniency to do it at all, if it was just the dentists that were administering that. That was kind of the question, is
I believe they are
whether it was making it more restrictive or
supervised.
opening up.
No, I think it's clarifying.
Okay, thank you.
Thank you. Okay. There was a question also about 201 KAR 039030, which is under the Board of Interpreters for the Deaf and Hard of Hearing. I know in administrative regs there were some concerns. This is a reg that highlights requirements for licensure and clarifies that the regulation only applies to applicants for full licensure, as temporary licensure is covered. I think there were some questions about reciprocity. Is there anyone here? Okay. Okay. So if our folks from the okay. Oh, thank you. Okay, we have Marva Johnson with the Kentucky Board of Interpreters online. Marv, are you available?
Hello, yes, Marva Johnson, Chair of Kentucky Board of Interpreters, and Sarah, our legal advisor, is on medical leave and she was unable to join, but I will try to answer questions as best I can.
Okay, can you just talk a little bit about what the concerns were from the interpreters?
The biggest concern was with the EIPA being recognized for full license. The EIPA is not a nationally recognized testing mechanism, and the KBI had no way of distinguishing the difference between an educational interpreter and a community interpreter. So what was happening is educational interpreters were also working out of their scope in places where they shouldn't be working because they don't have the training nor the certification level to do that type of work. The EIPA, with it not being nationally certified, it's more of a specialty plan. So like we have the National Interpreter Certificate, which is a testing mechanism that gives you entryway into working as an interpreter. And the EIPA is for education only after you gain access into, after you pass that entry level test, and then you can go on and take your EIPA and become an educational interpreter. And we recognize in the state of Kentucky, recognize the EIPA as a full license without passing that entry level test to say that you're qualified to even be in the field.
Okay, so are you looking for some sort of provisional license or a temporary license for individuals who take the, and for clarification, EIPA is the Educational Interpreter Performance Assessment. So if an individual meets those qualifications, you're just saying that you don't feel that they should have to sit for further examination or certification?
The EIPA is not recognized as a national certification, so it's a specialty. And in our full license in the statute says it, in order to gain full license, you have to be certified by a nationally recognized certifying body, and the EIPA does not meet that standard. So a person that is working, that we grant a full license to, that can work the whole gamut of work, should have that nationally recognized certification. If the KDE or the school district, or whenever they hire an interpreter, it should be a nationally certified, recognized interpreter. And then they can further require the EIPA, because that means that they will have that specialized training to work in the educational settings.
Okay. So
whereas we also have legal certificates that are recognized once you're nationally certified. We have mental health certificates. Once you are nationally certified, you can pursue those avenues, and you actually are required to have those specialties to work in those special settings, if that makes sense.
It does. I just have a note here that says that part of the opposition during administrative regs had to do with making it potentially more difficult for out-of-state interpreters to receive a license in Kentucky, and that it was acknowledged by everyone that there was a shortage of interpreters in Kentucky. And the discussion at the subcommittee meeting centered mostly around whether or not the current certification requirements met the statutory requirements for certification by a nationally recognized organization. So do you feel that we need to defer this regulation for more work at this time?
I personally, no. And it's not the view of KBI, because there's actually not a whole lot more we can do with the regulation. Now, it was proposed that a statute could probably be created for that niche, for the educational interpreters, that will separate that specific license outside of the full license, to whereas we could make sure that if they meet the criteria to be in the educational settings, they're not working in the doctor's office, they're not working in the legal arenas with this. But as it stands now, they get a full license, they obtain a full license with the EIPA, and can work in any setting. And it's on the responsibility of the hiring entity to know which test that their interpreter walking in the room has passed. And it's confusing for, it could be confusing for interpreters themselves. So how are we supposed to expect people that are hiring interpreters to know that this person passed this test, this person passed this test, this is their scope of work?
So you're looking for just creating some consistency.
And being able to have some appropriate oversight.
Okay. Will you get together with some folks to make sure that, if there's some statutory change that's needed, that this happens?
I would be more than happy to.
Okay. All right. Are there any other questions? Okay. I think that is all we had. My apologies. We just have a lot of regs here.
May I deactivate my camera now? Or
yes, you may. Thank you so much for
Thank
being
you.
here. Thank you.
Thank you.
We do have another reg, 907 KAR 1044 and 907 KAR 15005, establishing definitions and covering requirements for community mental health services. These regs were found deficient in the October 15th meeting of administrative regs. Do we have anyone? I think that Mountain Comprehensive Care has some concerns. Is there anyone here who would like to speak to this? Thank you for being here. Just introduce yourself for the record. Your microphone's not on.
Good afternoon. I'm Jonathan Scott. I'm a regulation coordinator for the Department for Medicaid Services.
Do you recall the reason why this was found deficient in administrative regs?
We did not have a specific reason that was given to us by the Administrative Regulation Subcommittee.
Okay.
The general history of this regulation is we are proposing to expand the mental health associate and rename it a behavioral health associate, and this provider type will be available in about 2,000 additional facilities if the reg were to pass, were to become effective. And they would become available to be in provider offices, in behavioral health multi-specialty groups, in behavioral health services organizations. Currently, right now, they are a non-licensed educational type that is available in a CMHC. So we filed the regulation last year. I think in November of last year, we filed a amended after comments version in February. Then we paused and began to defer it. We worked with 13 CMHCs and their representatives. We also worked with multiple licensing boards who are concerned about, the unlawful practice or the unlicensed practice of, for example, social work, psychology, several other disciplines that individuals who are MHAs could be practicing in CMHCs. So we worked with them, produced a couple of amended after comments versions of the regulation, of both regulations that we proposed. We did not, however, receive a listing or any information directly as to why they were differed, or as they were found deficient.
Okay. All I have is that Mountain Comprehensive Care regarded the new qualifications for individuals that provide behavioral health services, that it would ultimately create an access to care issue for behavioral health services in rural communities because many individuals do not and would not be able to obtain new college coursework requirements being proposed by the cabinet. Do these regulations require additional coursework?
Yes.
Okay.
So we are proposing that the BHA be an individual that is matriculating towards higher education, that they be enrolled in a graduate program. There are a couple of exceptions to that, especially for narcotic treatment centers. But other than that, these need to be individuals who are able to be connected to a licensing board, or who are under a employer or a provider who is licensed. That's the general.
Okay. So these are folks who aren't currently licensed or certified?
That is correct. MHAs are currently not licensed or certified.
Oh, MHAs. Okay. So is there any opportunity for working with some of the providers, or do you feel like you've already done that? I mean, I'm wondering if somehow we need to grandfather some folks in and give them more time or whatever it takes to get them up to certification.
So the way that we have looked at it is there are other opportunities for folks who are practicing as MHAs. They can move into other types of certification settings. They can move into other types of ways to serve in the healthcare system. But we are asking that individuals who are BHAs be moving towards licensure in some way, that they be in school, that they or that they have completed their coursework, that they're attempting to be under the licensure of a board, because these are folks who currently could be diagnosing who could be providing high-level behavioral health services to individuals. And our concern is that Medicaid individuals are receiving a lower level of services from folks who are not fully licensed and who are not going to be
Providing
adequately
services.
served.
Right.
And another concern that we came up with is we are paying costs that are consistent with, just within a couple of dollars of what we were paying for psychologists and LCSWs and other folks who have advanced degrees, so that there's not a substantial cost difference between what we're paying for unlicensed bachelor's only staff.
Okay, thank you. I understand now. Okay. And I agree. I'm just trying to make sure that we are giving some support to the folks who are hoping to move into these higher levels of healthcare. So, all right. Okay, are there any other questions on this regulation? Representative Fleming.
Thank you, Chairwoman Mosier. Could you quantify the number of individuals that fall in this category that you're trying to get them to go up to have a license in order to provide that service to equate to the comparable pricing or fees of other professions?
So we have heard across 13 of the CMHC divisions that it's the number could be as high as about 1,600, 1,700, and then we also have heard testimony in October that Mountain Comp had 1,600 alone. Individuals that was we have also heard that they only have about 400 folks that are MHAs. So it's not entirely clear. This is a group that's not under any licensing board or who is well tracked, because the information that's coming to us isn't necessarily indicating that the service was performed by anyone but a licensed provider, just the way the building works.
Okay, and correct me if I misunderstood or did not hear you correctly. I have one more question, Madam Chair. Sorry for getting permission. You said you have not heard back from groups in this regards. Is that correct? And if so, have you gone back out and reached to them? Because I feel like that's left hanging,
Sure.
and trying to get be more of a members or licensed or potential license friendly.
Sure. I would say Mountain Comp did not comment on the regulation. They did not participate in any of the work group meetings that we had. We had meetings with the CMHCs and the licensing boards. There were at least 4 licensing boards that submitted comments, and so we had I think maybe 5 or 6 meetings with all of them, where we rewrote the regulation, where we're pushing it, where we're pushing the effective date off to 2031 as I think the first point in time that anyone could have been subject to being removed from being an MHA, and then we created 6 years for folks who are in a 60-hour master's program. Again, where they would have an extended amount of time to be a MHA or a BHA, and then also we allowed for direct doctoral folks to have as long as 10 years to be functioning as an MHA in a CMHC or BHA setting. So I may have lost my train of thought in that. Did you?
You got there a little bit, but I think it's enough to chew on. But thank you.
Okay. It seems that we have quite a few questions about this, and administrative regs obviously had some concerns. I think I would like to defer this today just to give us a little bit more time. And also the Senate doesn't meet until the first part of February, so we've got some time. But I would entertain a motion to defer this today. Well, actually, we have 2 regs. So we'll we'll entertain a motion on 907 KAR 001-044, the proposed regulation. I need a motion and a second. Okay, all in favor of deferring? Aye. Any opposed? Okay. And then for 907 KAR 015-005, the proposed regulation, which is also part of this conversation, we will entertain a motion to defer. Motion. I have a motion and a second. All in favor, please say aye. Aye. Any opposed? Okay. All right. Thank you, Jonathan.
Thank you.
All
Thanks.
right. Okay. So we have gotten through those questions. Do we have any other questions on any of the regulations that are before us? Nope. Okay. All right. Well, I will consider the rest of the regs reviewed, and we will move on to the rest of our agenda. Thank you for your patience. We are going to hear from the Hospital Association. Nancy Galvani and Jim Muss are with us today to discuss the ATRIP program, the Hospital Rate Improvement Plan. So, welcome. Please introduce yourselves for the record. I know that you submitted a PowerPoint, so I think we'll get that up and you proceed.
Right. Wonderful. Well, thank you so much, Chairwoman Moser, Vice Chair Duvall, and committee members for having us here today. We are very excited to be here today to share the wonderful success of the Hospital Rate Improvement Program, which we call ATRIP for short. So when we say ATRIP, that's what we're talking about. But we really want to thank you. You've been a wonderful partner in the legislature supporting this program, along with the cabinet, and the cabinet secretary who is here today has been a champion of this program, and we have had just wonderful success. And so we appreciate this time today to tell you about the success of this program. And so for some of you who might not be familiar with the ATRIP program, ATRIP is known as a Medicaid state-directed payment program, and this program allows Kentucky Medicaid to draw down additional federal funds at no cost to the state. And that is because the hospitals pay a provider tax that funds the state portion of the share that we have to put up to draw down the federal funds. Under this program, hospitals are able to receive funding, additional funding, at 95% of the average commercial payment rate. And this is for both our inpatient and our outpatient Medicaid populations. And this is very, very crucial because our base Medicaid payments are well below the actual cost of what it is costing the hospitals to care for Medicaid patients. So this is bringing those payments up to 95% of the average commercial rate. What's really important for you all to know is that ATRIP is also a value-based payment program because hospitals have to meet certain quality improvement criteria to actually receive a portion of the payments. So perhaps unsurprisingly, with the addition of the resources that ATRIP gives our hospitals to work on quality, quality has measurably improved in a number of areas. Our hospitals have been investing these funds in training, implementing new processes, and undertaking additional measures to improve health outcomes for our patients. And we are very excited to be here today to share the statewide improvements that have been made possible through this critical program. So let's start with readmissions. Unplanned readmissions are a significant cost driver for Medicaid. And because of ATRIP, we have seen major improvements in the readmission rate for Medicaid patients. Our hospitals have been able to reduce unplanned readmissions from a double-digit percent, you can see here 10% baseline, down to a single-digit 6% in just 1 year. Hospitals have also used ATRIP resources to focus on reducing sepsis and infection rates, and we're seeing success on both of these fronts. Sepsis, as you know, is not a single disease, it's a syndrome in which the body has a dangerous, overwhelming reaction to infection. If not caught early, the likelihood of organ failure and death is significant. Early identification and treatment of sepsis helps to avoid expensive ICU stays and saves lives. KHA had already established a sepsis consortium a number of years ago in which all hospitals participate, and that consortium has allowed for the sharing of best practices, training, and implementation of procedures to identify sepsis early and allow for fast treatment. The measures that hospitals are using in this consortium have been incorporated into the ATRIP program. ATRIP and the additional funding has made it possible for hospitals to screen 98% of patients visiting the emergency room for sepsis. And if those patients screen positive, they're getting very quick treatment. Similarly, other infections have been reduced due to the ATRIP program providing critical resources. The reduction in infection, of course, is good for patients. It's saving the Medicaid program resources by avoiding the cost of longer hospital stays. Opioid use is also being reduced thanks to ATRIP and our statewide opioid stewardship program that KHA established back in 2019. Measures from the opioid stewardship program have also been incorporated into the ATRIP program. And there has been a sustained focus on reduction in opioid prescribing, and that's resulted in successful reductions in patients getting multiple opioid prescriptions. Virtually no patients leave the hospital with multiple opioid prescriptions, and we are now having alternate pain management as the norm, as the standard for things like ankle sprains for patients that come to the ER, and aftercare for non-complicated vaginal births. ATRIP is also allowing hospitals to focus on new mothers in a way that was not possible before these resources were available. This is important because nearly half of all births in Kentucky are covered by the Medicaid program. We know that postpartum depression is a real and present danger to the health and the lives of new mothers. ATRIP has allowed Kentucky hospitals to screen new mothers for postpartum depression and substance use disorder within 2 weeks of discharge from the hospital. If a patient screens positive, the hospitals are able to refer the new mothers to resources to help them. ATRIP has also allowed hospitals to screen for suicidal ideation, and over 1 million patients visiting the emergency room have been screened. As you may know, suicide is the second leading cause of death for youth and young adults, exceeded only by traumatic injury. The ATRIP program made it possible for this screening to start last January in our hospitals, and we've been able to screen 90% of patients over age 11 who visit the ED and refer them to proper help. We often hear about the social determinants of health, or sometimes called the social drivers of health. And what that really means are things like food insecurity and lack of transportation. And these determinants of health are important drivers of unplanned readmissions. Hospitals have undertaken a vital effort in screening patients and referring them to resources. The hospitals are also key partners in a new Food as Medicine program, along with Commissioner Jonathan Schell at the Department of Agriculture and Secretary Freelander at the Cabinet for Health and Family Services. This program, while separate from ATRIP, works in conjunction with it to help patients receive more fresh, local Kentucky produce and proteins. It's a benefit to patients, hospital employees, visitors, and Kentucky farmers. And so we hope to come at another time, along with Commissioner Schell and Secretary Freelander, to tell you more about that specific program, what we're already accomplishing in that program, and what we hope to do with it. KHA is exceptionally proud of the role that our association plays in the functioning of the ATRIP program. We're proud of the quality improvements of our members and excited about the potential for further transformation of healthcare in Kentucky. KHA has provided training to more than 1,000 people in just the short time that the ATRIP average commercial rate program has been in place. We've also engaged top experts to help our hospitals have access to the best information and the best practices for helping patients. KHA collects data from our hospitals and provides that to our partners at Medicaid, and we provide feedback to hospitals regarding their performance. Remember that ATRIP is a value-based program, and performance by all of our hospitals across the state is important to move our entire state forward. ATRIP has allowed our hospitals to invest in their staff, both with training and with salaries. At a time when there has been a wave of hospital closures and salaries have been stagnant in other states, ATRIP has given the resources to allow our staff pay in Kentucky to keep pace with inflation. Fewer staff vacancies means better care for patients, better outcomes, and reduced readmissions. I can't say it enough, but ATRIP has been absolutely transformational for healthcare in Kentucky. And again, we thank you for your partnership in helping support this program and allowing our hospitals to stretch their scarce resources to provide these better outcomes for our patients and your constituents. Without ATRIP, Kentucky's hospitals would be operating at a negative 6% operating margin. That would mean less access to vital treatments. It would mean less access to care in general. When I meet with hospital CEOs, both large and small, they tell me they don't know where they'd be without the ATRIP program, and some of them tell me they'd probably be closed. We don't have to speculate about these matters because we've seen the loss in service and even hospital closures in other states that don't have a program like ATRIP. Our hospitals have been able to invest in treating our patients in a way that simply did not exist before ATRIP was introduced. We are very eager to build on the gains we've made and to continue to improve the health outcomes for our population. And again, thank you for being such great partners in this program. We appreciate the support of the General Assembly and the Cabinet, and we look forward to continue to working with you and coming back to this committee to talk about the great gains that we're making for our patients. Be happy to take any questions.
Thank you all. So without Doc Bentley here, I kind of feel like talking about rural health care needs to be taken up by somebody. So my district's spread across 4 counties, and I've got 4 hospitals within those counties. And it's kind of interesting because they're, I've got a private, I've got 2 larger chain hospitals, if you will, and then I've got a small nonprofit. And over the interim, I've talked with all of them, met with all of them, toured them, and I wanted to know how ATRIP was working because last session we also had another rate improvement bill that had passed because ATRIP alone doesn't seem to be enough, particularly in rural Kentucky where we've got such a high Medicaid dependent population. And so I've asked each of them, what are you seeing? They're all very grateful for ATRIP, and based on your presentation here, it kind of echoed what they said. Without it, we would be looking at cutting services or having difficult conversations about reducing services and or worse. And so we got to talking about other possible things that wouldn't necessarily cost taxpayer money, and that's kind of when I started learning about the 340B program. And one of the CEOs gave an example where they were able to increase salaries because COVID made everything competitive, particularly in healthcare, for staffing. And then we've recently done a Medicaid rebasing rate with nursing homes, and apparently that's starting to cause some issue with staffing as well. And so they kind of went into that, and they talked about how that program, in combination with ATRIP, made it possible in rural settings to keep the doors open, one, and then offer to be more competitive on staff. Is that an isolated incident, or are you all seeing that across the state, particularly within rural hospitals?
340B is critical, absolutely critical program to our hospitals. The 340B program, as you has pointed out, does not cost, there's no taxpayer money in there. All it is a discount that certain hospitals, not all hospitals, but safety net hospitals are able to buy outpatient medication at a discount. And by paying less, then that frees up some money that they can then direct to staff salaries, to keeping the doors open, to other services that they wouldn't be able to offer unless they had a subsidy. And the fact is, and I talk about this all the time, but when we look at the patients that are in Kentucky hospitals, because we do have a lot of poverty in our state, 70 to 80%, and in some cases 90% of the patients that are in our hospitals are on a government program. They're on Medicare or Medicaid. The number of patients that are commercially insured is going down. If you think about our population aging, we're seeing more people move on to the Medicare program. Medicaid's staying about the same. Commercial's going down. And commercial is the way that you traditionally would subsidize the losses. But when you have 70, 80, 90% of your population on Medicare and Medicaid that are paying below cost, that's not sustainable. So ATRIP has been a godsend as far as the Medicaid program. But Medicare, we are one of the lowest paid states in the nation. We're not even paid at the national average for Medicare, and the federal government sets those rates. So the 340B is an important program that hospitals that are safety net hospitals, and what I mean by that is they have a large number of, government vulnerable populations. They're serving, a tremendous amount, which is most of our hospitals in the state that are nonprofit qualify for that. That's very important for them to be able to have those savings to help shore up the losses that these hospitals are having. And it's only going to grow as more people move into the Medicare program and less on commercial. So that is very vital. And so, yes, the hospitals, we have some hospitals that have told me that if they did not have the 340B program, they probably wouldn't be open.
Thank you, Madam Chair.
Thank you. Representative Proctor.
Thank you, Chair. I just have a question for you. I'm glad to hear you're being proactive in some of these things, and we're like the sepsis and seeing that coming down. My question is, with a lot of these patients, there's comorbidities, there are lifestyle issues, nutritional issues, and what's really easy is to give them medication. Is there a proactive approach on how to change some of these issues so that we don't have these chronic diseases and chronic issues that are leading to, or just more pills or surgeries or things like that? Is there an emphasis going to be on that?
Oh, yes, that's the whole Food is Medicine program. As we have started doing the social determinants of health screening, and that's 25 questions. It's a CMS questionnaire that we are going through with our patients to identify housing insecurity, food insecurity, transportation issues. It's a whole list of things. The number 1 and 2 things that are coming up is food insecurity and transportation. And we have set up this Food is Medicine program in conjunction with Jonathan Schell, with the cabinet, to really hone in on better food. Because you're absolutely right. Take diabetes, for example. We have some hospitals that are seeing results in putting support groups with diabetics together, trying to encourage them to have healthy foods and eat better. And they're starting to see, that managed better, or maybe, great improvement in the health. So that is where we want to go with that program. We're just in the beginning phases of that and trying to put a work plan together around that. But we agree with you. We absolutely need to get at these lifestyle issues. And healthier eating, we think, is a great way to address a lot of the chronic conditions.
Okay, thank you. I really appreciate your being here. I have a couple of questions about the data collection that you talked about, and I know that there's some federal rules around data collection, and we've had some discussions in the past about kind of where that happens, how that's being utilized and accessed. And then, in light of the ATRIP programs and these programs that are really assisting with some of these great things. I love the Food is Medicine program. I love, that we are now screening all patients for mental health disorders and postpartum issues, suicidality. Are we tracking, number one, are we tracking kind of the return on investment? Some of the things, you've outlined some of the programs that are being really enhanced by the money. Do we know, yet what some of those outcomes are looking like, some of the trends? You're talking about readmissions for one. That's a very good thing. So is that something that the data is being used for?
Well, the readmissions, of course, and we're using our claims data to look at that readmission rate. That's something that we've been working on for quite a while. I think the social determinants of health screening is new, and so we can track the number of referrals that are being made, but we're not really able to track at this point, did the person follow up on the referral? Right. So, that's going to take more data to really look at, connecting, I guess, with all the different referral sources to really go at that point. And at that point, that person isn't really a patient of the hospital, so there's HIPAA issues around that. Yeah. So, but that is something that long term we do want to look at. But yes, we're absolutely using the claims data for a lot of these quality measures that are in the program, looking at sepsis, looking at compliance. So that's wonderful. And then things where, we need to get more from the medical record, the hospitals are reporting that data to us.
Right.
And I know you wanted to hear a little bit about transparency and what hospitals are doing. Do you want me to touch on that?
Yes.
So our hospitals, of course, have always worked with our patients to help them understand the cost of their care. They have financial counselors. And we periodically do public polling because we want to know, what do the patients want to know? And what we consistently hear back is that people really want to know, what am I going to owe? Less than really what's the total charge. They want to know what they're going to have to pay. And when we ask people, are you shopping? What we're hearing is they're shopping for ancillary services, maybe like lab work or x-ray, but they're really not shopping for a hospital admission. But nevertheless, the federal government has put laws and regulations in place that hospitals are following around transparency. So I thought I'd just briefly hit the highlights of those. So the first one is known as the Hospital Federal Price Transparency Rule, and that's been in place for 4 years. It took effect January 1st, 2021, and it requires hospitals to post on their website, where you can easily find it, which if you go out to these websites, it'll be called transparency. It'll be very obvious where you can get this information, and it requires the hospitals to post 5 different types of charges: the gross charge, the discounted cash price, if there is one, their negotiated price by each third-party payer, and the de-identified third-party payer minimum and maximum negotiated price for every item and service offered by the hospital. So you can imagine these are very voluminous files. It has to be on the website. It has to be in a standardized format, in what's called a machine-readable file, for the purpose of being able to be downloaded. And there are companies out there that download this information, that have created shopping tools. So that's the purpose of that. And it has to have a description of the service and the billing code. And, not every hospital offers the same service. It's not going to be, not everybody has the same contract with the payer, so there's going to be differences. But there are rules around standardization as much as possible of that information. That rule has a second part. It's called shoppable services. So the rule requires hospitals also to post prices for what the federal government defines as a shoppable service. And this is known as a service that can be scheduled in advance in non-urgent situations. And so the federal government gave us a list of 70 of these shoppable services, and then they said they want the hospitals to fill in another 230 based upon the most frequent services that the hospital provides. So it's a total of 300 shoppable services, and the hospitals can either post this information in the machine-readable file like they do their standard charges, or they have the option to provide an internet-based price estimator tool, which is more consumer-friendly, and that's really what most Kentucky hospitals are doing. The second part of the transparency, federal requirements, are known as good faith estimates of expected charges. And this was part of the No Surprises Act that was passed in 2022. It took effect January 1st of 2022. And this doesn't just apply to hospitals. This is any health facility or health care provider. And it requires these providers to provide a good faith estimate, which is the expected charges for whatever item or service you're getting, including any facility fees. It usually applies to somebody who's not using health insurance. So this is somebody who's uninsured, or if you're insured and let's say, you haven't met your deductible, so you're not using insurance to pay for your care, then, you can get one of these good faith estimates. And the provider has to do it on request, or if you schedule a service 3 days before it's going to happen, then you can get one of these good faith estimates. Now, they only list the expected charges for a single provider. So, for example, if you were having outpatient surgery, you would have to get one from the hospital and the surgeon. So each provider is responsible for giving their own estimate. If then you get one of these estimates, and when you get your bill, it's more than $400 difference above the bill, the good faith estimate, the patient can go through a new federal dispute process if they wanted to dispute the bill. So again, most people, actually when we polled this, half the people that we polled said that they had gotten an estimate in advance of services. But again, most people are really shopping for those lower cost ancillaries. A couple things to keep in mind again when we talk about price. The federal government is setting the price. If 70 to 80 to 90% of the patients in the hospital are on Medicare and Medicaid, that is not a negotiated rate. The federal government sets that price through regulations. We don't get to dispute it. We're not even paid at the average. And then our Medicaid program, outside of ATRIP, it's tied to Medicare and actually pays less than what Medicare pays. So that's why we have to have this ATRIP program to, increase our payment above these terrible rates. The other thing to keep in mind is that hospitals are subject to laws that no one else has to comply with. And one is called the Federal Emergency Medical Treatment and Active Labor Act. And sometimes you'll hear people say EMTALA, and that's what that is. And that says that any patient that comes to the emergency room of a hospital has to be screened and treated without regard to ability to pay. No other healthcare provider is subject to that. So if you think about a free market and what happens in a free market, no other business could stay in business, much less make a profit, if the federal government dictated their payment below cost and they said anybody could come into their business and, would have to get the services basically for free. So as I talked about, by necessity, in the past, the hospitals were cost shifting to commercial payers, but that amount of commercial payment is going down. There's fewer commercial patients in our hospitals. And then when you look at our commercial insurance market, it is dominated by one insurance company. So there is very little leverage of our hospitals to negotiate even within the commercial insurance market. Also, just like to point out anytime I can that the RAND Corporation, if you've heard of them, like a think tank group, they put out a report every year called the National Hospital Price Transparency Report. And what they do is they look at commercial prices across the United States. And in every year they've done this report, Kentucky is at the bottom in terms of commercial prices compared to other states in the nation. We are one of the lowest cost states for commercial prices in hospitals, according to this, not KHA, this national company. So as far as data reporting and claims data that's available, there's been a law in the books for over 20 years that has required hospitals to report all payer claims data to the Department for Public Health. And this is all inpatient and outpatient, uninsured, all payers. And over the years, that's been expanded to where outpatient licensed facilities and ambulatory facilities are also reporting that information. So if you think about everything that's on a claim form is in this database, and so that's your diagnosis codes, it's your procedure codes, it's demographic information on the patient, it's the age, the county, the ethnicity, the race, all of that. So it's a wonderful data source. Our hospitals use this data source when they do their community benefit analysis and their community needs assessment. So they go out and they can look at, what are the diagnosis, what are the health conditions of their service area. That's what they use to plan their services. What do we need to expand? What do we need to develop? And we know that other agencies use this data as well. The Department for Public Health and I believe KIPRIC uses it. I think the opioid people that talk about the overdose use it. So there's a lot of great information in it, and it's really available to anyone. You can go on the Cabinet's website and you can request these data sets. Also, I'll just put a plug. The KHA has established a transparency site on our website. So if you do want to visit our website, that is under our data section. It says transparency, and there's a lot of great information that we're putting out there, trends in hospital utilization by payer, data on births, and then we've linked to a lot of great reports that are out there on the Cabinet's website. So I'll just put a plug in for that, and of course we'll be expanding the data that's on that as well.
Okay, that is great news. It's exciting to know what's out there, and I just wanted all the members here to really understand the federal transparency laws and what you're doing in conjunction with other healthcare providers. So thank you for this report. And I can't wait to talk more about the Food as Medicine program and really learn more about how ATRIP is assisting with that and other partnerships that can be kind of accomplished through all of this. So thanks for your work on that. Thank you for your work on really promoting alternative therapies to opioids. We worked a lot. I worked a lot on this issue when I first came in 8 years ago, and so I think it's exciting how far we've come. And I remember some of those early conversations with trauma surgeons and who had great ideas, and now it's kind of blossomed into this great kind of program. So
I would just say Kentucky's leading. We are leading on so many of these issues, and we get calls routinely from other states about this program and about our quality results. We're ahead of so many other states.
That's great to hear.
Yeah.
All right.
Madam Chairwoman, before you wrap up, I just wanted to say thank you, Representative Proctor. Your question was so much appreciated because there needs to be a lot more proactive work. It really needs to be about health care rather than sick care. And one of the things that we're working on, and we may be coming back to you at some point, we're doing an inventory on kind of barriers to our being able to be proactive. And fortunately, we're not running into as many at the state as we are at the federal level, but we may be coming and talking to you about barriers to that and seeking your partnership so that we can make sure that we are able to move forward that way.
Great. All right. Well, we're always happy to partner with you and others on improving our healthcare in Kentucky. We have a lot of work to do, but I think we're making good progress. So, all right. Thank you so much.
Thank you.
We will see you all in February, if not before. And I have one more announcement before we adjourn. There is some contact information which the new members should have. So if you could just make sure that staff gets your contact information, that would be great. Is there anything else? Nope. Okay. So our next, I'm sorry, Representative Dotson.
Real quickly, I just want to record my attendance.
Oh, absolutely. And I want to thank Representative Dotson for serving as my vice chair for the last 2 years. He's moved on to another committee, and I wish you well, but I'm glad you're still here. So, all right. Well, thank you all. We will send out the agenda for I don't know the date of the next meeting. Last page. The next meeting is scheduled for Thursday, February 6th at 12 noon here in room 149. So seeing no further business to come before this committee, we are adjourned. Thank you so much.